Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 123. We apologize for the delay in starting the case today. Multitude of reasons related to some issues in the cath lab, the patient, and even the troubling traffic which comes and disrupts things without a moment's notice. We have a interesting complex coronary intervention today, calcified, highly complex procedure requiring probably a left ventricular support, but let me have Dr. Kinney and Dr. Sharma provide you those details and take you to the cardiac cath lab. Anu, Samin, good morning. Plan still to use the left ventricular support?
Yeah, I mean, this actually gets a little more complicated than we announced it, and we are going to discuss that. This has been an interval change in this patient, and we welcome all our CCC live viewers, episode number 123 from the Mount Sinai Cath Lab with Anu here and my fellows on the right side with Parashram, and we actually have fellow from Italy. He's attending, actually goes to many meetings, Dr. Angelini. Actually I have a special guest today. We always get time to time. Usman Babar, because what I'll be talking about some platelet trials which just came out in European Society of Cardiology, and we needed to have we know quite a good knowledge of the platelets, but we need platelet guru, and Usman being here will give some comments and so. So with that note, we start this particular case because we're already a little late. Let me just go through 1 second. Can we show the slides, please? Yeah. So this is the patient. 62-year-old male, first time has crescendo angina, class 3, and has a strongly positive stress MPI. With the EFI is about 50%, has hypertension, hyperlipidemia, non-insulin dependent diabetes, good medical therapy, and 3-vessel disease, which Anu is going to show, and the EFI is 50%. And you start with we can show the angiogram now. I'm sorry, the real angio.
Yeah.
Yep.
So this is you can see the axis. This is the right, which is calcified, but more important, I think I can show you the angio of the left, where you see a lot of calcium in the femoral. You see this 360-degree arc of calcium even there.
Yeah. Oh, yeah.
Yeah.
Look at that.
And that's where we were questioning, should we really need Impella or no? EDP was 25. And if you see this LV gram, I know it's not
40.
a pigtail LV gram. We still, I would say it is between 35 to 40.
Probably even a little more, I thought.
I mean,
It was originally, but it definitely looks low now.
Lower,
And we'll tell you why.
lower.
Yeah.
And this is what I'll tell you. We'll keep going. What we did, we definitely decided on Impella. So if you go to the angio, right coronary artery, we know it's totally occluded. That fills via the bridge. But the left side is something new. You see the distal left main?
Some thrombus
Whether it
in
is
the distal left main.
looks like there is a thrombus versus there. And the, I think, circumflex lesion which we mentioned, which is already there. And this is where the LAD heavily calcified. Moderate disease in at the level of, I think, mid LAD, at the level of the diag. Diag is 95%, but LAD is still about 50-60% at the level of the diag.
So
and further down, there is diffuse disease.
Straightforward decision point here would be comparison with the previous angiogram. If the left main distal area is new, then I think we are dealing indeed with thrombus here. Yes, clearly Samin totally changed the altered case, totally changed management and approach.
And we saw that actually there was nothing in the distal left main a few days ago.
Right.
Yeah, so this is now the left side. We just want to tell you the axis wise. If you see, the right was worse because, occlusion of the SFA further down. So we decided we'll go to get this axis with the large bore sheath on the left side. So the technique that has been described and many people are doing is that you use 14 French CP Impella, and through the same 14 French sheath, you can then introduce a 6 French guide or a sheath or a 7 French sheath or a guide. So if you can just show, this is the 14 French Impella sheath. If you can focus on my.
I mean, you wonder why this innovation was not tried before. Makes complete sense. You've got a big bore sheath there. Access the second one through it.
So
Usman, we see you. Welcome.
Yeah.
Hello, hello.
So
Dr.
now
Mehta,
if you see the sheath, this is where it is. And if you take a needle, right, we have a needle here. So either at see a 1 o'clock or 9 o'clock position, you can puncture. And then this is once the impella is in, the impella will be through the central lumen, and you puncture on either of these side, you puncture that way, and then you go back, you wire it and then introduce your sheath and then the guide. That's what we have done here.
There is no
So
possibility.
if you can focus here, you see the impella as well as our 7 French sheath.
Yeah, they can center it, please, a little bit. No, they are not centered it. Can we center this a little bit?
Let's
on
put
Dr.
the
Keeney's hand?
on Dr. Keeney's hands. Yeah, we'll get it in a moment.
Yeah, good.
Here we go.
Put that
Yeah.
in the center. Yeah.
Perfect, perfect.
And the most important thing which we learned, that you don't put that 7 French sheath through the same hole where you are putting an impella. Because impella is 9 French. The 14 enough room, you don't put it through it because they need to leak and bleed. We did at the time of our yearly the CCC symposium. We put this was the second case we did, and it went through the same main hole, and that caused a lot of bleeding around the sheath and across, and really was trouble. So you have to puncture it, and then you'll be able to advance 6 or 7 French, whatever you want, very easily, and they're very tight fit, as has been shown. See very nicely now, showing very good.
Yeah, if you can, yeah. This is where. So you have the
Excellent,
impella.
excellent. Yeah.
You see the impella, and then
Yes,
our
Very-
yeah.
Now,
Okay.
one limitation is that you can do it only with the CP,
Only CP,
only with the CP.
not with
Well, the regular one nobody's using much now. The
14.
CP offers, it offers so much advantages. The augmentation you're getting is close
You
to
have the
5
iOS
liters
ready?
as opposed to 2.5.
ACT is good.
So,
And same with the large bore sheath, we are using heparin. ACT is 295.
So, Samin, a question for you here. Again, with the distal left main possibility of thrombus, Impella makes more sense.
yes.
But why did we, let's say, if that was not there before, with the fairly...
He was on Plavix.
Yep.
Right.
Once the patient, the refused surgery.
Go back to the slide.
He was
So we'll go back
discharged
to
home
there
on
now.
Plavix.
And I mean, clearly, you see this
It
now.
could be the-
At that time, patient actually was, initially plan was to do it at the same time versus what patient was on aspirin, did not start any the P2Y12 inhibitor because we want a patient appropriately with a diabetic with a syntax score of 39 and EF about 40, 50, 45% is appropriate for coronary artery bypass surgery. So he went for surgical consultation, and then after the heart team discussion, PCI was decided. So that's where we are. So patient was not on any the long-term antiplatelet therapy beyond just aspirin. So now the goal today is because of calcific Impella assisted protected PCI of calcific LAD diagonal bifurcation along with OM2 using rotational atherectomy and of course multiple DEFs. But things changes now because the left main, we are going to interrogate the left main and then decide.
No, but once the PCI was decided, I discharged him home on Plavix.
Okay, he went home on
He
Plavix.
was on
Okay.
Plavix.
So he
after
was
that.
on clopidogrel
I mean, it's
then.
probably, whatever,
Samin-
for 10 days
Samin,
now.
Two quick questions for you.
I'll put it from the region now.
If you look at your
Come
slide here, the EF is written as 50% and the plan was still to use an Impella, which is very different than what we have advocated the last few years, that unless you have severe impairment of LV function.
Right.
Is this on the basis of the new data coming with the emerging use of the Impella for more protected PCI?
Yeah, so I would say absolutely. We always have maintained that we do only with a 35% EF for the left main and 30% for multivessel disease. But some cases, and particularly young person like him who has multiple options, you want to come with a perfect. And that is where FDA last year approved Impella for complex CAD, but that require that it's not a surgical case. Surgeon have to say that a patient, the PCI after discussion, PCI is approved. So patients, you can do now Impella is allowed based on the guidelines, even in the patient with normal ejection fraction with a complex CAD, but has to have a consultation by the surgeon, and patient has to, the decision was made, the patient will get PCI.
Okay, we are doing
So
IVUS
that
now.
is what exactly we did. This is one of the rare one which we do, yeah.
Next question before the IVUS, Anu, very quickly, and either you can answer or Usman. How about the use of cangrelor here?
Not at this setting. Let's see what it shows. Okay, there.
No,
That's
but in
at the
this
level.
case, I would say this is the kind of case with a high risk. There is nothing wrong in that. I mean, the
I mean,
cangrelor can be used.
with the thrombus in the left main, I thought there would
No,
be
no,
a
it is
little
not
it is.
thrombus.
Or is it a
No,
calcium?
No, it's just
Let's
calcium.
flush it a little
Okay,
bit, we
done.
don't see it better.
We done.
We saw it?
Let play. I don't want to leave
Play.
it for a long time.
Okay. So what question is, what I would do definitely in this particular case, since he was on clopidogrel, will give 30 milligram loading dose of prasugrel and then give 5 or 10 milligram based on what we need to do because of the age and weight and stance. We give 5 milligram very liberally.
So right
very
here,
few
right
cases
here.
10, yeah.
This is all calcium.
Yeah,
No
see the-
thrombus. Yeah,
Huh?
it's all calcium.
Yeah, the acoustic. So it is a calcium. So
Go
but
back,
prasugrel, 30
And
milligram, yeah.
you had not seen it during the recent angiogram?
Yeah, there,
in the
there, right
patient,
there.
yeah?
They did a very limited picture on that day. Maybe.
Got
Yeah,
it.
we did.
Yeah.
Look at that again. Pablo, you can get the old picture film. Maybe you can see in the. Try to get the old film there.
So
how to
Anu,
do
here is another interesting question for you. How much do you think if instead of, again, with the left main that makes it actually messy, but I was going to ask whether a OCT delineation of thrombus may be better, but again, not in this distribution.
The only
So
question is, remember it's a acoustic shadow, white echogenic area, and then there is no shadow behind. So it speaks for the calcium.
Right.
On the based on the criteria on the IVUS. So I think we just go ahead and do it now. Good.
What?
Start with the OM.
Okay. Now I'm just concerned here. Okay, stop there. Yeah, it is calcium. See there?
Yeah.
You don't see
Remember,
anything
no
behind.
shadow behind.
Behind.
Circumscribed,
Yeah.
Eccentric calcium. And then later on, you will see even at 6 o'clock position as you come further. Is the old film playing now?
You could always have thrombus
Outside.
on
No, no, not outside. We did the cath.
No, in the outside computer it's playing.
Here you can't.
Recently I'm working for
It's broken.
the web sampling is
Not working. Okay, so now we will go to the.
Tell somebody to play. I'm going to go and see it. Yeah.
Yeah, wonderful idea, Samin. I think it's good. Somebody should take a look at it.
Plus the cross-sectional area is how much? Left main.
Make that on the key loop and play it. There's one loop, put on the key and we have to play it.
So, Samin, here is the benefit which I also realized this morning. The new wireless mics give us a possibility of moving around freely.
Yes. Very good.
I take this out, right?
Usman, were you there at the ESC?
No, Dr. Mehta, I was actually on call, unfortunately.
Okay.
So
I think somebody has to
but,
do that too. But yes, a lot of exciting work there coming.
No, there absolutely
What's
was.
the view? Go
I
to the
think a
same
lot
view.
of trials that will have a major impact on practice.
Right.
So I was able to listen and watch from a distance.
Wonderful. And just to point out to our viewers, I hope that they are able to appreciate our improved transmission and methodology, major change in the alignment, how we have the three cameras showing each with its dedicated purpose, the hemodynamics, the imaging. It did require considerable adjustments in the first couple of cases, but hopefully now we can continue to take advantage of the numerous benefits. Far clearer imaging, much more purposeful, much easier for us to manage, and it's very hard for people to see that. But if you will notice carefully, there are no cameramen in the room. Advancements in technology. Samin, you're viewing the angiograms.
We're going to show it now.
Okay,
Actually, you know
excellent.
what? Somehow it was not a good picture,
Right. Okay.
good engagement, and it is there. It
And
was
you,
there.
right. Okay. And you also appreciated in specifically that shallow RA view.
And then once you give a large with a guide catheter, you see the shadow, you'll have a
Absolutely.
disease there.
Samin, what are the topics you're talking about today?
So
I
we'll
think
be
let's focus on finishing the case and then
a
we
little
can
bit, yeah.
decide
we'll
on the
do.
topic,
Yeah.
right?
No, but
Later
while
on.
you are wiring, you're going to
No,
get a
okay.
guy too.
I think so.
Okay, get a guy too.
Don't move, don't move.
Okay. Get the guy too. One less mag.
What wire do you have there?
This is a fielder.
Fielder.
Okay. XT.
Okay,
Yeah.
went
Anyway,
in.
it went in. No, regular
Okay.
fielder.
You
Regular
just
fielder with just
needed to threaten it that you're getting a Gaia.
no. I
Get
mean
the rotor.
with the fine cross,
Don't
you know,
need,
you
yeah.
just went
Right.
a little bit
Absolutely.
further, and that's where the area.
Where's the rotor wire?
And now we have a rota
Yeah.
floppy wire. Just make sure we are in the lumen there distally. In the
Cine?
no, not cine. Now you can go low mag a little bit. Yeah, some dye.
Samin, what was the thinking? Why did you decide to approach the circumflex first?
Subtotal, no?
Because one patient has ischemia all over, but in the infralateral area, it could be from the RCA, was the severe, and it was moderate to severe in the anterolateral and mild to moderate in apical.
I mean, another argument which could be made is it's a very large LAD, easy to do lesion. Do that first, and that protects you to do the complex lesion in the circumflex too.
Yeah. So we'll try to do quickly while they are doing the, ready?
Yeah.
Take the wire out? Yeah. So
Now,
while doing the-
LAD, if you are not going to do anything to the diag, you're going to lose diag. If you're going to do something to the diag, it's not an easy lesion.
yeah, it's a
Absolutely.
Diag
bifurcation.
is very complex.
Yeah.
Calcified osteo may need rota also there.
Yeah.
No, I
So-
was actually
1.25.
thinking of just the LAD, but you're right about the diagonal.
Yeah,
Anu, how
diagonal,
much?
it's a good size.
Yeah, how much is the Impella support at this moment?
Right
3.5.
now,
How much? 3 and what? 3.5.
3.5.
3.5 liters, yeah. Okay, so now we are going to go through the regular process. Can we talk meanwhile, or what do you want to
so
do now?
1.25. Okay, I'll do the rota.
Okay, so we are going to do rota, show it rota on the one side and slides on the other. So basically, it has been wired, that OM2 has been wired with a fielder wire, exchanged with the, to the rota wire with the fine cross.
Anu,
So we
did
can
you
show-
consider a 1.5 or 1.25 was
It's a very small RT. I
automatic
think
choice?
1.25.
Okay.
1.25.
125. Yeah. So, okay, what we can do, bring the picture on the left side.
We see it very clearly.
Yeah.
Please proceed. Yeah,
And bring, yeah, good.
excellent.
Oh, yeah, it's actually bigger vessel. You want to go to 1.5? That's okay. 1.25 is fine. That's all right. Yeah. Okay, mega vessel. Look at this. Why it was a large ischemia? Okay, so now while we are doing it, since we have shown the rota quite a bit, can we bring the slide on the main screen and the rota on the left side? And now there is no, yeah, that way we change it, exchange. Good.
There we go.
And just show the flora on one side, yeah.
Excellent job, Dolan.
Beautiful,
Excellent.
beautiful. Now, so just to appropriateness point of view, 3 vessel, diabetic patient, high syntax score, so it is M. May be appropriate, but in this case is appropriate because of the heart team discussion. So that become our class 1 indication is the heart team. After that, patient is, we give the fact to the patient. Those all should be done in the outside the cath lab environment, and patient may still like to go like this particular case. So coming back to the points, as you mentioned, European Society has a lot of very exciting trials. So I put it in 2 separate categories. One is the THEMIS PCI, ISI React 5 and popular age, and then the complete trial of the STEMI strategy. So the first one is our THEMIS, and it's basically what wanted to see, because remember what is happening. That we know aspirin alone is not enough patient with CAD. They keep having events. So we keep testing with a new agent. First we tested with the clopidogrel in the Karishma trial. Then we tested with the prasugrel. Then we tested with the ticagrelor in the Pegasus. And then we had now Odyssey using rivaroxaban. So we are keep adding the agents. So what is the result? We are having more bleeding, although little more efficacy, but more bleeding. So whole concept in this group was large number of patients that ticagrelor in patient with a stable CAD, those who did not have MI, with or without PCI, and see what happens to these patients. So Usman, you want to comment on it? Why anybody will think about it even?
Yeah, I think you're absolutely right, Dr. Sharma. I think it's about identifying populations for targeted therapies. What we know is that patients with prior MI, we know patients enriched with risk factors such as those that were studied with the rivaroxaban study COMPASS trial and from the DAP trial clearly benefit from more aggressive antithrombotic therapies. What we do not know is whether or not a similar paradigm would be seen in patients with diabetes who are at high risk for atherothrombotic events, but still don't have a history of prior MI. So this was a population of diabetics without prior MI, and in fact, in this trial, there was a reduction in ischemic events, but only 10% on a relative scale, and that was not sufficient to counterbalance a twofold increased risk in bleeding.
Yep. So the key was, so even with rivaroxaban in the COMPASS trial and so all showed more bleeding. There's a little more ischemic, but more bleeding. But anyway, this is similar. The message was that we have spoken about large number of patients, about 20,000 patients. Look at that, ticagrelor versus placebo, and represented globally, like 1,100 centers and like 30 plus countries. These are the various risk factors. Showed what we expected, that death, MI and stroke from 7.6 went down to 6.9. So clearly, but reduction is about 10%. They expected reduction of about 16%, right? They felt based on the data will be at least 16%. So we say, okay, you know what? Not a big deal. We at least got the 10% benefit. Okay, now let's say, and these are the individual endpoint, no difference in death. It's more of a myocardial MI and of course lower stroke rate. So question was that these are the individual endpoints of the clinical outcome. The subgroup analysis, but more important was here, safety. So, okay, you saved a little bit in the ischemic point, but guess what happened here? Major bleeding is 1.2% higher in the ticagrelor. You know, initially they started 90 milligram. Then in the course of the trial, because Pegasus showed 60 milligram was better, they changed from 90 to 60. Correct. Even then, combine all, look at the major bleeding and of course the intracranial hemorrhage, significantly higher compared to placebo. So therefore, it was a big issue when this trial was presented. You combine both of them, and then of course the outcome, the discontinuation of the drug, and so which has been much higher, half 2/3 because of dyspnea, 1/3 due to bleeding. So quite a heroic trial, little benefit from the ischemic point of view, but clearly that from overall point of view remains questionable. So they concluded basically is that maybe not in every case. So I would say after the trial, if Usman, I want you to summarize the Themis trial results in one sentence, what would you say?
I think the summary would be that in a stable patient with diabetes without a history of overt coronary artery disease, prior MI, a strategy of ticagrelor plus aspirin is not better than aspirin alone.
Okay. Usman, what does that leave us with the non-diabetic?
Well, I don't think we've really tested that. The only data we know that are clear in secondary prevention is Pegasus, which was a prior MI cohort, and in COMPASS, where again you included patients with prior MI or actual PAD. So I think the key theme that we're seeing, it's not the mere presence of the risk factor, it's actually manifestation of an atherothrombotic complication of CAD, such as a prior MI or actual PAD. Those are the patients in whom we clearly see a benefit for more aggressive and prolonged antithrombotic therapy, which was not tested in Themis because these were patients who had CAD but did not have a prior MI. I think that's the most important point here.
Yeah. And therefore they concluded, so let's stay tuned for Themis PCI and let's go for Themis PCI. Basically was the group of the patient in this of 20,000 that who had PCI. So they have pre-specified and try to see whether ticagrelor works better in those patients. So idea was same, 9,600 had ticagrelor and 9,600 those who had PCI. Those are the patient, Themis PCI was like 55, 58, and 5596 in patient with the placebo group. And see here overall outcome, patient who have PCI and no PCI, and very important difference. If you have history of PCI and you are diabetic, there was clearly significant reduction, 15-16%, which we expected originally in the trial, really happened into the patient who have history of prior PCI. And the no history of PCI, you see on the right side, curves were identical. And these are the individual endpoints, which I have put it here. History of PCI on the left side, no history of PCI on the right side. Red basically is the significant difference on the primary endpoint, MI and stroke, in favor of ticagrelor. And then of course you go to the safety. If you see the history of PCI, there is definitely a bleeding issue, but clearly with the no history of PCI was more significant. So again, we got the same issue, that there definitely was some issue with the bleeding.
Yeah, no, I completely agree. And I think the controversy here was that the interaction tests for the formal primary secondary outcomes were actually not statistically significant. However, it's plausible that if you have patients with a prior PCI, the DAPT score already showed us that diabetes increases thrombotic risk, and in those patients you do better with prolonged platelet inhibition. And I think we see a concordant result here with them as PCI.
And good thing is that your major bleeding means fatal and intracranial hemorrhage was not different. Correct. At least that was good in the PCI population. So bleeding was there, but the real serious, which kills you, is not there. So that was the good news. So here, if you combine all points, MI, stroke, fatal bleeding, intracranial hemorrhage, you can see here there is a benefit in the PCI group with a net clinical benefit, but not in the non-PCI group. So basically, on treatment versus those who are intention to treat are shown here. Basically, it seems to be that patients who have PCI and ticagrelor and diabetic do better. But some bleeding, yes, but not a fatal or intracranial hemorrhage. And that was the conclusion of the trial. And this adds to the many of the trials which have been done in this field with the ticagrelor. So Themis after Pegasus and show add on to with the plate. So now what will happen is, because the bleeding is a major issue, in the same issue of the NIDDM, we have now another paper, which is the antibody for the ticagrelor reversal agent. It's very interesting. First time has been tried, and as you can see here, that immediately by giving the drug, when you have what happened, patients were on ticagrelor, and they gave this antibody, either bolus or bolus and infusion, and you see that 20% means platelet reactivity. Now aggregation becomes lower. The aggregation is it means platelets are inhibited. If not, then clearly that by giving the infusion you reverse the effect of ticagrelor. So very positive early data of this reversal agent. So this basically the conclusion of the Themis and Themis PCI, and now we actually having antidote. The question always comes, we compare the Triton, benefit is always there in the ischemic, but at the cost of bleeding. Both Triton, Timi, Plato, everywhere the same was. And the question always comes that what about if you compare ticagrelor with prasugrel? So this is basically the trial. We have only one trial so far, which is the Prague 18. Which showed no difference in the STEMI patients, supposed to be 2,500 patients, but they had to stop after 1,200 because of futility. There no benefit of one versus other in STEMI patients done in Prague. And now we have another trial which compared ticagrelor with prasugrel in patients with acute coronary syndrome, and that was basically the background of the ISAR React 5. Because we have indication at present that you give in a non-STEMI the ticagrelor as soon as possible, and you give prasugrel after you have done the angiogram in those patients. And based on that, the trial was designed to compare ticagrelor with the. You are ready now?
Yeah.
Stenting?
We are ready for stent. What stent you want?
Whichever you want.
Put it 2538.
Yep, good. Yeah. So we just, I will finish this one while you are putting the stent. It will come on the screen. And so basically showed the femoral, it was radial was done in about 1/3 of patients, and various characteristics are shown here. Majority of done with the on heparin, and the patients overall the unstable angina 10%, non-STEMI 45%, and STEMI 44%. So basically showed that in these patients, comparing ticagrelor with a pressure on 4,000 patients, you have a clinical endpoints were better with a pressure compared to ticagrelor. Now, difference of 9.3 going down to 6.9, knowing in this all the trials of the Plato, Triton, difference was barely 2%. And this was such a unremarkable 3+% difference, and of course there was no difference in bleeding. So I definitely will ask Usman to comment on it, because no other trial has shown, even in the trial when we compare the potent P2Y12 with the clopidogrel, we did not see such a remarkable difference between two agents. What happened in this trial?
I think there are three, as you mentioned, Dr. Sharma, three important points. One, this is the first time prasugrel has really performed this well. As you mentioned, the rates with prasugrel here are much lower than in Triton, whereas the rates for ticagrelor are comparable to what was observed in Plato. That's point one. Point two, which is also very interesting, is here we see less thrombotic events, but no difference in bleeding. As you mentioned with Themis and Themis PCI, this is paradoxical. One would not expect less thrombosis, but no change in bleeding, and that is very surprising. And third, if one believes the results of the study, one must assume that prasugrel is literally a more potent agent than ticagrelor, and that is somewhat contrary to pharmacodynamic studies that have been conducted previously. Nevertheless, as you mentioned, this is the largest adequately powered randomized trial. It was well designed, it was conducted, proper endpoints, and there is a reduction. So until there are new data to counteract this, I think this will certainly emerge, perhaps, certainly create some controversy, some discussion, and may in some patients influence practice.
Okay. Now, can we go on to the fluoro, because we're ready to put a stent here. Put a fluoro on the main screen, please.
Usman, absolutely right. I'm sure it will generate a lot of controversy, which is quite normal, you know, when you've got two head-to-head comparison of agents. Samin, I noticed something very intriguing in the slide you showed from Themis PCI. 31% of the patients were treated with a bare metal stent.
Yeah, a lot of people still in the outside, you know, but America and many places, of course, they concern, particularly patient, you know, worried about
the cost of a bare metal stent around the world is $125, and the cost of drug-eluting stent is $126. So
no, but maybe outside, maybe a little more.
Yeah,
India, both are the same. But both are same in Europe, and so maybe a little different.
Both stents sell for $200 around the world now. It's unbelievable.
Okay, Anu, tell us now.
No, we did a stent.
Yeah.
We just finished the stent. We did a Rota 1.25 bar, 2.5 balloon, and this is where we are. We did a spot stent.
Looks very good.
But then you want to do a proximal, right?
What happened? Little dissection, no? Dissection branch.
Yeah,
that's a branch that was there when we were wiring. It got opened up. Okay, then you want proximally you want to put another one like a 18, right?
Okay. Yep.
Get us a 3.0. 18 proximally.
Which
to that OM itself. This
maybe
is a science we have.
Maybe a little longer than 18. If you want to.
I think 18 okay, because you don't want to go to OM1 otherwise. Yeah. And then after that we'll proceed to LAD.
I think the major question in this case will remain the lumen of the left main is more than 8.
Yeah.
And that should you do anything to the left? And you remember all the trials were 6 millimeters, some of them even 5.5. That 6 is good enough. And actually the trial showed that once you do left main PCI, make sure your lumen is 8.5 and above. So we are 8.57.
Yes.
The question comes that do you want to leave that eccentric lesion versus what? I think based on the case, right? Anu, that's your feeling?
So, yes. Samin, here is a question. I'm trying to read from what is the source. I cannot make it out. It's not even a question. It's a statement. In this case, Impella is an overkill. How about that?
Well, I would say that overall, I would say, yeah. Because the only question is that do you want to get a perfect, no complication during procedure? So that is a softer indication. So I would not say the overkill, but is it absolutely necessary? Our answer will be no. But key is what Impella will do, that will be able to give us a perfect result, will not be worried about that abbreviating our interventional strategy. Now, having said that, apparently those angiogram is ready as soon as Anu is done with this stenting. We'll show that angiogram of the previous time. But yes, if I'm teaching, I'm asking somebody that is this a case for Impella? I would absolutely agree that this is not a case for Impella. Here, our threshold for Impella was just because this is a young patient, has a mild to moderate LV dysfunction, not to that our degree which we usually teach, but at the same time complex anatomy, and therefore we want to come up with an excellent result. And particularly once we saw this left main, though I think that overkill word will be a little more aggressive, but key is that can it be done without Impella? This case, answer to that question is absolutely yes.
Down. Now you have to take the entire thing into account. Yes, there was some questionable issue with the vascular access, but once that's why I think you see every time during all these meetings, large bore access has become an important part, because large bore access not only good for structural but even for high risk PCI. High risk PCI which is stable, or high risk PCI when you're taking care of shock patients, because Impella has become a part of all these procedures. So now this case, your question is same, did you need Impella or no, or could you have done with the balloon pump? You could have used both, but once you have seen 3 vessel disease, you're going to definitely do rota of the circumflex plus minus rota of the LAD diagonal, and EDP was 25 with I would say EF is 35 in this patient. I think the EF that we have just seen. Taken everything into account, and if you think you can safely do Impella, you should do in this case. Yeah. So the word overkill is not acceptable.
Samin, the picture we are seeing is the one from before on the top. Is that
no, we are going to bring it to the main screen.
Not yet.
Just
not
one second.
Yet.
Yeah. So let's see the picture now, and then we show the picture from last the 2-3 weeks ago. So patient was sent on clopidogrel, and we gave now prasugrel 30 milligram. Now just went back to our, in our lab, we use prasugrel about 12 to 15% of cases. Of that 12 to 15, 90% is me. I have always believed in prasugrel.
Yes.
Always believed in it. But different dose. If you are already on clopidogrel, loading dose of 30 and 5 milligram, except in cases where weight is 100 kilo and above, and we have put more than 3 stents. Those will get 10 milligram. Yeah.
ISAR React 5, does that make you change anything? Use it more?
To me, I think for others, maybe. But I have always been a very proponent of the prasugrel. Yes, it
nice
will be
results, no?
Our decrease will lower our threshold, changing from ticagrelor because of the lot of symptoms. Yeah.
Okay, now
so
we
can
go
we
to
show
LAD?
the old one? Okay, show the old one on the main screen, please.
I mean, that
The
is a very,
picture, yeah.
angiographically, it's very worrisome.
Yeah, good. Here. Okay, so this is the patient. And you
Not
need
yet,
to control,
later.
yeah. So now it is playing. So this is the run number 1. Very,
Oh.
okay,
looks
go to the
quite-
next. Go to the next.
Quite different.
Yeah. No, but you'll see more. Yes, here.
Okay.
See, there is a distal left main.
Sure, there is,
Yeah.
but
It was there, but go back again, previous picture, because we have only 2 frames or 3. Play again. Because what happened is not a full injection. Many times I say when you have suboptimal injection, it many times makes lesion look less or versus, if you see on the other screen, I could see a little bit of shadow. But anyway, we are just to say, next picture, there is clearly very eccentric lesion. See this now, distal left main. So it is there, but they have not taken a good picture, and your 7 French guide was not there. So with that now, note they have done the circ intervention and going to the LAD, and we can go back to our discussion back again for the presentation.
Let's do a plan,
Yeah.
LAD plan.
Okay, let's talk about the plan first. Go to the picture.
First plan.
Okay, they can remove the old pictures now. We don't need them. Yeah. Okay, let's go to your LED picture of earlier. Yeah, right there. Good.
Go, show us for us.
Let's see what we are going to do with this one. Plus.
So we actually checked the PRU
Plus.
for the patient. He was on
Plus.
Plavix, is 353.
So Plavix, so see clopidogrel, PRU, platelet high reactivity, anything more than 230 is bad. So clearly the right decision that we change. There is actually mid lesion which was 60%, looks much more now, and calcific. Then there is a diagonal disease. See that?
Diag should just go cutting balloon.
Cutting balloon,
and
yeah.
stand
So
across.
I think we use a 1.75 bar.
No, but then LAD, what are we going to mid distal?
Distal. Yeah, look at how calcific LED lesion is at 3 o'clock. The mid, look at it.
No, mid to
The
distal?
rampant. Yeah,
You want us to go there?
1.75. Yeah, definitely. Which one?
Yeah, at the
Down?
bend.
No. Just 3 o'clock position.
Not 3.
Just 3, whatever.
This one.
Yeah, this one, yeah.
And this.
So,
Exactly. Those two. And cutting balloon of the diagonal, yeah.
so
One strand will not cover it.
No, two strands. That's okay. Yeah. I'm sorry. Yes, sir. Samir?
I'm sure one of the key elements in your mind is that we have the Impella catheter. Let's
Yeah.
do the LAD.
Right.
What would you have against somebody if they were saying that, look, the circ was difficult enough, let's bring the patient back for the LAD?
Well, the only question is, in this case, we already went through that. He already have an angiogram, and now he has come back here. So I think we'll bring him back for the RCA intervention. That after a couple of months. That time you can see left main progression, what happened to your PCI site. So, but this case will come back for stage 2, but for the RCA. RCA is also doable, as you can see here. We saw that angiographic point of view. So RCA has a total occlusion, but all doable. Little complex, but something which we do it nowadays very easily. So while they are ready for the 1.75 burr for the LAD, we can go back to the slide presentation, please. Good. So ISAR React 5 showed no difference in bleeding. And actually, numerically, look at the stent thrombosis, 1.1 in ticagrelor and prasugrel is 0.6. Makes me believe maybe it was adulterated ticagrelor for the trial. I mean, you don't have that stent thrombosis. But anyway, we have to just take the trial the way it was done. And remember, the issue always comes. One of the important issue always was it was open label. So people have criticized the trial. It was open label, and then you give ticagrelor before. In many cases, while prasugrel was only given after the angiogram and PCI decision was done. But that's the way practice is. Anyway, so this is basically put both of them together in the 1 year endpoint individual subgroup analysis as shown here, and particularly when patients are younger. Prasugrel actually was better. So less than 75 years of age, we know prasugrel works quite well. So basically showing that first time we have comparative trial, large comparative trial, besides Prague 18, that comparative trial of ticagrelor with modified prasugrel. Because what happened is they gave 5 milligram in less than 60 kilo or more than 75 years of age. I'm sure they gave 5 milligram to many other patients also. So that really, this strategy worked very well and showed quite a bit. Now, right now you can see the demise of the ticagrelor in the European Society of Cardiology. We got 3 trials. Now get to the 4th one. What happens to the old patient more than 70 years of age who have acute coronary syndrome called popular age trial? Because we all know that guidelines are showing that P2Y12 inhibitor should be used, but also we know that they are associated with higher bleeding. TIMI 38, Plato. So, but what about patients who are, and of course, those who have bleed, they die, which we all know. And older patients of 75 makes only 10-15% of other population. So this trial, so what happened to the patients 70 years and above? I don't know why they selected 70. Why not 75? Yeah. Usman, do you have anything? Why?
No, they may have just looked at the feasibility of including patients, and they've just been much harder. It may have been a practical decision, not necessarily a biological one.
Because anytime we talk about the age, we talk about 60 or 65, 75, 70s.
And I think it's important, if you look at your traditional STEMI or true ACS trials, for example, if you look at just ISAR React 5, your mean age complete mean age is in the low 60s.
Right.
So you're still getting a population which on average about 10 years older here than what we see in our traditional ACS trials.
Okay. So therefore, this was a trial of 70 years old patient with an acute coronary syndrome, non-STEMI, randomized. They got a loading dose, reloaded even if they were same 300 or 600 milligram, clopidogrel, ticagrelor 180, prasugrel 60, and then you give 5 or 10 milligram dose, whatever your the choice is, and clopidogrel 75 milligram daily. Primary endpoint was the bleeding, and of course the clinical benefit having the efficacy endpoint, and basically showed if you take it together, all cause, the death, CV death, MI, and all of them together with the patients. These are the individual baseline characteristics of these patients, and so on and so forth, and basically showed the bleeding. Clopidogrel having a lower bleeding compared to ticagrelor. So, well, we knew about it, that clopidogrel patient will have a lower bleeding. But guess what? The more important, the bleeding point of view, clearly clopidogrel wins. But more importantly, efficacy point of view. You can take a death, MI, and a stroke. They were identical, no difference. Actually, if you think about ticagrelor, although has a slight p-value is 0.06, because you combine the bleeding also. But if you take only MI, death, and stroke, were identical in group right here, identical. Death, MI, stroke, identical. Lower bleeding, that made the efficacy a little better in point of view. So another trial which really made the ticagrelor touch the dust, which is unbelievable in patients more than 70 years of age. Can we go back to the angiogram, please? What very difficulty there? It's a 1.75 bar. Put a fluoro on the main screen. Yeah, good. So tell us what 1.75.
Yeah, we did the
First lesion was no problem.
yeah, second lesion. We'll see. Maybe I do a little bit dyna and go further down.
Okay. So now we can show the hand. So we are going to advance the burr distally.
Good. Now this is what one person can do it. So you see this?
Okay.
You
Show
can
the
hold.
hand. Yeah, they're showing it. Yeah.
How to work with the dyna. So if you see, 1 second, they need to see my fingers properly so that they can see well. Okay.
So now question is the long lesion. You have done the burr. Initially you have to advance
So you
the
go
burr.
on dyna. So dyna, you same. You have to break release, press the dyna. That's what you do. And then with my left hand, I'll advance the burr. Good. That's how you advance.
And advance
but
the
you
knobs
see
to be
that?
tight.
Yeah, the advance and knobs tight. So now you still have close to 8 centimeter of your length.
Yep.
Now off dyna, that means you're done and start burring again. This is where that lesion was tight.
Very calcified, very calcified.
I think we are good.
You did?
I don't want to do that turn.
Quentin, you want to take a little picture?
You can't see much.
Increased speed.
That means
Little
make
idea.
it done.
Yeah. Huh? Just
Okay.
put a little there. Just very little.
Yeah, you did it.
Yeah. They do one more, yeah, but done.
Good.
Just a little polishing.
Mm.
Good. Good.
Yeah, it's 1.5 could have made it. 1.75, don't push it.
Okay, that's fine. We did that lesion.
Hmm?
Good. So 1.75 has been done.
Yeah,
Now
coming
the
out.
dynaglide will come out.
Yeah, press, ready? Good. Start coming
Okay,
out.
let's go back to our slides again, please.
Run
Wire.
through wire. Get me the run through wire.
We can show back to the slides now.
Okay, good.
Bring the slide to the main screen. Okay. Now, Usman, you want to
Yeah.
comment on it? Now, should we change our policy? That patient more than
Run through
70
was
years
here,
of age,
man. Why you get
should be using just the clopidogrel? Actually,
Yes.
Anu always believed. She believed more in clopidogrel than anybody else in our lab.
Well, Dr. Sharma, I think the trial wasn't, in my opinion, not definitive enough to necessarily change practice. I don't think the findings were all that surprising. Yes, there's less bleeding. And again, wasn't really
put it
powered
in the water,
for
right?
the ischemic endpoints.
No.
But I think it really gives perhaps some evidence to those
Always
individuals who might
make sure
prefer
this is in the
clopidogrel
water.
in older elderly patients. I think this can be used as that. But I don't think it was definitive enough, particularly with the combined endpoint, missing non-inferiority, to really change practice.
And this actually, they called it that they compared ticagrelor, prasugrel, but prasugrel was in 10% of cases.
Right.
90% was the ticagrelor. Okay, so now let's go to the second one, which was the complete trial of the STEMI strategy. Now we know that we have 3 trials we have done, combining, all showing actually whether you do a culprit vessel or the full revascularization during the same hospital admission or so, with the PRAMI, culprit, and primulity, the showing, and there is a trial called compare, which is not there. So all showing that one way or other, multivessel revascularization was better than the culprit vessel revascularization, and that changed our guidelines back in 2015-16, which in the past used to be the doing non-culprit vessel PCI was harmful. Class 3 became 2B because of these 4 trials at that time. So complete trials say, well, let's go to large number of patients and let's look at the strategy. If you do multivessel, you do it in the same hospital admission or you do it after the discharge. Is there any difference? And this was the trial done again by Dr. Shamir Mehta from Canada with Dr. Salim Yusuf, and excellent trial. The whole goal was that large number of patients, you can identify the earlier trials of the PREMI and culprit, they all showed benefit in the reducing ischemic revascularization. There was no difference in MI or death. So this trial was powered for to show the answer that whether culprit versus complete revascularization favors one versus other strategy in the death and MI as the primary endpoint, and other endpoints are there. So basically what happened, 2/3 of the patients who were complete revascularization were done in hospital, 1/3 were done as an outpatient, and the overall, these are the group of patients and the various agents, as you can see here in the previous slide. Ticagrelor 64%, prasugrel 10%, clopidogrel in about 25% of cases. And this was not a trial of very complex PCI because the syntax score was about 15, 16. Once you took away the culprit vessel, syntax score become in the single digit of the non-culprit vessel. And when in the non-culprit, when they did a revascularization, the syntax score becomes 0. So that's a very, very interesting finding. So what did we find? That if you have a complete revascularization, which is in the blue, compared to culprit only, there was a difference of 1% with a very significant p-value, and number needed to treat is 37 patients to decrease 1 death and MI. Very, very remarkable concept. And of course, once you put the ischemic revascularization, again become 50% reduction, and now you only need 13 patients to reduce 1 death, MI, or ischemic revascularization. So these are the individual endpoints as shown here in these cases, and I have put it together in a bar graph just to show very clear-cut data. So Usman, are you surprised with the data?
Yeah, I think, you know, this closes our, you know, circle. We started with PRAMI. And as you mentioned, small trial, big effect. This trial shows us convincing for the proper endpoint, death or MI, a 25% reduction for that very important endpoint. I think this is very clear in the absence of shock, albeit in somewhat low-risk patients, as you mentioned, not much diabetes, average age 60 to 61, but clearly a strategy of complete revasc was better, and this should change practice, and this should be reflected in guideline updates.
Very
Osman,
important.
Osman, two questions related to this. First of all, it convinces us that the pathology happening here is probably beyond just the culprit lesion. You know, there is maybe some inflammation which is contributing to it. And the second part is that, well, I'll let you answer the first one and then move to the...
No, completely. I think we know in acute manifestations of acute atherothrombosis have a peak, which then tends to degrade over time. And that's probably due to vulnerable plaque, inflammation, so on and so forth. And therefore, your opportunity to realize a benefit is also in the first several weeks to several months. And I think this trial supports that basic biology.
So clearly, complete revascularization is supported by data. What about the timing?
They're showing it.
Yes, and I think in this context, particularly for different practice patterns in the United States versus, let's say, Europe and Canada, I think this is crucial. For obvious logistical reasons and other reasons, we may not be so enthusiastic to intervene in the same hospital admission, let the patient go home, make sure they can take dual antiplatelet therapy, then bring them back in a few weeks. And this trial would completely support that strategy because the reduction in events was independent of the timing of revasc. I think that's a very important feature.
Finally, where does it leave the role of FFR for these patients?
Yeah, I think that's a great point. You know, with findings have been somewhat different with greater FFR use. If anything, FFR use leads to even better outcomes with PCI. So if anything, I would suspect perhaps the events would even be better if they had done more FFR use. But I think that's an important point that wasn't really tested in the trial.
Okay, let's bring the fluoro, please, on the screen. And we'll come back to this. Just we have a few more slides, but this is more important. Anu, tell us what you want to show the last picture. No picture, what after your Rota, PTCA?
This is now we went with a fielder wire to the diagonal and just a 2 to 5.
Uh,
6, 8, 10.
Anu,
What is-
crossing the diagonal was not difficult.
No,
Wolverine. Okay.
Wonderful, yeah.
go up. This should have been on the side, so guys,
No, it was
people
showing.
could have watched. No,
No, but they're showing it earlier.
Down.
Till we asked the question, then only they came. Otherwise, it was showing
Down.
on the side.
Yeah, a little bit
Go up here.
we lost Anu, you're right on that, and we'll getting used to the
The
system.
fluoro guy, we had to take the instruction. Fluoro should 100% time should be on the
Be
side.
on one of the screens, yeah.
One of the
Yeah,
screen,
yeah,
100%.
yeah. We'll get it right.
Okay, ready?
I would like to, I want to stay
You want to
perfectly
put a little higher pressure.
proper
You
and
have to cut
ethical in this meeting. I would like to apologize to all our viewers today that for whatever reasons I have not been getting your questions.
Go up.
So it is my profound regret and my apologies if I have not been
That's
able
good.
to answer
Enough.
your
You want
questions.
more cutting?
I believe it's got something
Down.
to do with the new modality we are
Then
testing,
it'll
and we'll get that
dissect.
part right.
Okay. Take the rotawire out. You don't need.
No, the stent will not go.
I see.
Okay, give us a stent quickly. So we'll put a 28 down there and then maybe another one.
3 or 28.
And
3 or 28 first.
it may
So we'll
have
go
to
with a
do-
3 or 28 to the distal lesion and then maybe a 3 to 5 long one to the proximal part of the, mid LAD. Now we are going to mid to
sounds a
distal.
plan. In the meantime, Anu, the patient has been tolerating extremely well. No issues at all.
No.
Yep.
You
Okay.
can see show the hemos. We cannot
One is
have
still
this. Remember, one screen should be hemo, one screen should be the fluoroscopy all the time. So they're
Here we
able
go.
to see the
Here we
EKG
go. Here we
changes
go.
and
Yeah.
That they did it. Yeah. The diagonal actually we thought earlier was a bigger vessel. It's barely 2.25, so that's okay. To use a bailout strategy, the stent crossover, and if you get something, then you change it.
provisional. Yeah.
Provisional stenting.
Okay. Flying, we're to apply brakes.
Usman, I want to thank you for coming in today. Valuable input from a true expert.
No, thank you, Dr. Mehta, and I thank Dr. Sharma and Dr. Kinney for
Good.
inviting me, allowing me to participate.
And next month we'll have Dr. Roxana Maran because she'll be presenting the date on twilight. Which
Good.
date is that they're presenting? On
September 26th at TCT.
26 at TCT. A major trial. Okay.
I
looks
can
good.
tell you that is going
Go up.
to totally change the way we practice.
We're hoping so.
Go. 16.
Because in every trial they've added a new agent. This
What
is
do
the
you want
only
to do?
trial where they've taken away the agent.
So what do you want to do? 3, 5, 33 now?
Yeah.
Right?
3.533. Yeah.
Okay, 3, 5, 33. Provisional stenting. You
But as
can
long as the
you,
diagonal
you
ostium
could have
opened
used a calcificate, bifurcate, all these aids. A lot of aids are coming.
Let's take a picture.
My nurse Vicky always says now she does not need an attending in the room. She can do it with the fellow using the bifurcate app. We just
Well,
had course.
once you have a full penetration of artificial intelligence, you'll be amazed how much it is going to be changed. The involvement of robotics is. I had a pleasure at the ESC to talk to Jean Fajade, and he was telling me about the robotic procedures he's been doing out of Dubai. How about that? So he goes every
Like
month
the
there.
software engineers who say they work from home, maybe soon we also can start working from home.
I think that is a stretch, but I think it is going to the impact of robotics. They just reported last night far greater penetration of robotics and AI with the open heart surgery.
Yep.
Cut wire.
You're okay. You look at enough preparation of the diagonal ostium. So that's what you are just pointing out to know that what is happening with the diagonal ostium. Do you need to cut a little more? It was 2.25, went up to what atmosphere? 18. Even then. And that's okay.
No, but further cut will be equal to we have to put a stent. It's already dissected now, ostium.
You want to put a mini crush now? That will be guaranteed coverage. 2.25, 12. No? What do you think? What's against giving a 2.25? Although because it's a good
Small
diagonal,
vessel.
young guy, huh?
Then get us a 2.5 high pressure balloon, 12. Let's
No, no.
open the ostium. Let's
see.
open it well and see first. Otherwise,
Okay.
then we go.
All right. So they were going with but not the cutting balloon. You want a high pressure.
Yeah, I think we cut it enough. We did enough cutting.
Okay.
Next, we then we can make a decision. Did the vessel daily?
2 minutes. So finish it, then you'll go.
No. We want more cutting? No.
Oh, okay.
Already
We're doing
did.
a high pressure. So let Anu do a high pressure. We finish our presentation and then we come back to finish the case, and then we'll go with our take-home message and questions. So right now with the 2.5 or 12, what length?
Yeah, high pressure balloon.
Non-compliant, 12 millimeter. Okay, can we show the slide
Have a
again?
2 to 5 stent ready, 12 if you need, or 12.
Good. So there's basically a complete trial. And now also just to see, is it better to do the PCI in hospital or do it after the initial hospitalization means discharge? And it looks like there's no interaction. So actually it seems to be that whichever way you want to do, that's okay. So that's another good news. So the strategy of non-culprit PCI, either you do 1 day or you do 3 weeks later, had an equal outcome. So that was a very interesting observation. And predefined subgroups are shown here, and these are the other points that it was not associated with any different bleeding or stroke rate and so. So it seems to be that we now have completed our non-culprit vessel PCI concept, that do it same time or later, but do a complete revascularization is better than the culprit vessel revascularization. And this adds to the 5th trial, which is complete on the right side, other 3. And then I showed earlier, compare acute and basically using the FFR. FFR was used in complete in less than 1% of cases. So it tells you, once you have an angiographic lesion, 70, 80, 90%, you don't need FFR to make your decision. And this was a very practical trial. So what will happen? Multivessel PCI in STEMI, will complete trial change the STEMI guideline? Well, I would say yes. Why not? So that's my feel. Hopefully by the end we'll get it, we'll make it a class 1, because I think the complete trial really complete this circle of the strategy, because we know cardiogenic shock, multivessel PCI versus culprit vessel PCI showing no better, only culprit vessel PCI up to 1 year, change the guideline, particularly in the Europe, that from 2A to 3.
Yeah.
So clearly changed. So I think the major trials will make the difference. Cardiogenic shock, you do only culprit vessel, multivessel PCI in the STEMI patients as shown there.
Complete reversal of how things were 2 years ago.
I know, completely the way we did it. Exactly. So if I sum it up, and I'll just then ask Usman to make comment, and then he can leave because he has other commitment, that what the European trials showed, which change in practice. Ticagrelor in diabetic without prior PCI, no good. Ticagrelor in prior PCI for diabetes, and clopidogrel in elderly, plus. And the real plus was prasugrel in acute coronary syndrome and complete revascularization. They are going to change our practice for a better outcome to the patients.
Absolutely, Dr. Sharma. I think ESC has had some practice changing and guideline changing trials. I think the most convincing was certainly the complete trial, as you just summarized.
On the main screen.
As far as ISAR React 5, my personal opinion is that this will reinforce existing practice patterns. So people that really, are believers of prasugrel and will continue to use the data, those who prefer ticagrelor may see the limitations of the trial. And with respect to use of ticagrelor more broadly outside of patients with prior MI, I tend to agree. I don't think really the findings are going to change practice or overall negative in that sense.
Usman, a very different statement, and it's more of an observation. I honestly don't even know the purpose behind it, but I'll still mention it because it was stated earlier. It was a little surprising that the data for complete was presented at ESC and not at an American meeting.
Yes, I can't honestly.
And you have a choice to say no comments.
Yeah, I honestly don't know. I think a lot of this may be driven by the timing that data
Right,
was
right.
complete
Exactly.
and accrued and timing of statistical analyses and wishing to disseminate the results. So I suspect it's more of a practical situation other than anything else, but I honestly don't
Absolutely.
know.
I'm sure that is indeed correct. And once again, thank you for coming over today.
No, thank you very much.
All right, Usman.
Thank you.
Yeah, I know you
Thank
have
you.
other
Thank you.
commitment. Now,
Thank you.
Anu,
Thank
tell
you.
us where are you having little trouble?
No,
Crisscrossing of the two
wires.
stents. So
Yeah.
you decided to put a stent in the diagonal because of not fully opening, right?
No, it opened well. We
Oh,
could just
okay.
leave it alone. I
Then?
think the only way now is either we have to take out the LED wire, because this stent is not going. Definitely some crisscross there. Now to do that, versus we just take the, this is the final picture.
Okay. So now question is, when you have crisscross of the wires, it always give you trouble, right?
Mm.
So let me show you one technique of floor. So we have to take this stent back out, right? So now you cannot deploy it. Okay.
Yeah, but which wire will you take out?
No wire taking out. Okay. So key is that you just go side by side. Now this is your wire. Put your second stent on this. Yeah. So we go together, one behind the other. We used to do it quite a bit in SKS. One little front, one behind. Now knowing that your side branch stent should not have any difficulty in going. Maybe that's why it's not doing it.
No.
Huh?
No, this is different. Is that okay?
Okay, press it. Yeah. Good.
You disrupted.
Huh?
Lot of disruption.
Yeah, get a new one. What length?
3533.
Yeah, 3.5. So what you do is you're going both attached. So what happens is the wire spins, and that wire is spinning is what the one which creates the problem. So what you do, we are outside, our wires are in good position. Okay.
My
So
question
just wait one
is-
second. No,
okay,
not
okay.
yet. Not yet. Get the stent quickly. So this trick will prevent from spinning of the wires. I tried few times and let's see if it works today or not. Okay, just one second. I'm holding both the wires, but first you put your LED stent inside. So just yeah, no, but put this one stent further a little bit.
No, it is enough. It's
Yeah.
enough.
No, go. Go the diagonal first. Diagonal has to be in the front. Keep showing the hands there.
No, they won't see anything. Okay, good.
Huh?
Okay.
Okay. Now they'll be able to see. Yeah.
Hold the wires.
Yep. I'm holding both of them.
No, see, wire came out.
See it very nicely.
Yeah. Yeah. Why? No.
No, let the fielder.
Yeah. Okay. Advance the fielder a little bit.
That's much better.
Okay.
Much better.
So we are holding both the wires. Yep. Good. Make sure your diagonal is in front. Good. So now you are advancing both of them.
Mhm.
Little different. Diagonal in front, LED behind. Going in or no? Which one is the diagonal? Diagonal is this. This is the diagonal.
Okay, looks like the trick is working.
Okay. Yeah. Yep. See, you brought both of them.
I know, but one has to, which is the diag though?
Yeah.
The one below. Yeah.
Guide. You need a guide one. So at least we are taken care of the guide catheter. No crisscrossing.
This is the diag.
Yeah. Now put a LED stent further down.
The
Distally down.
diag is the inferior one.
Yeah. Good.
You were telling me, and I was also diag LED problem.
Good. See? Good. See another technique.
This is very unusual and very nice, Samin. Wonderful. I thought we had learnt all the PCI techniques. There is always more. This worked
Always
very well.
something in the kitty.
Yeah, it's
Okay.
worked very well. Very nice.
Okay, this is DAG. Hmm?
You know, these companies have to be punished. They can't write the size
Yeah,
in a
can't
book.
read.
Can't
Piece of
read. You know,
shit.
people became like blind
Some
reading those
some
things.
dye there.
Which is the
This
diagonal?
is
Guys,
LED.
know it
This
or
is
not?
this is LED.
I'm the diag. Okay.
You need to
I
give
think we are
this,
good now.
Samin, a new technique of doing this. This is very, very
Ready,
smart.
ready. Inject. No. Let's go. Inject.
Good.
Looks
There's
good.
a gap.
Yeah.
You want to go in? I'm
In
going to go
more.
in with
This is
the.
the diag.
Little more diagonal, yeah.
No,
No,
this
no,
is the
no.
diag.
I'm going in with LED.
Okay.
Agree?
Good.
Some dye.
That's fine.
I thought with the diagonal too, no?
I will.
The diagonal is going to go in anyway. So otherwise, it's a macro crush. So now they're talking about ultra crush,
No.
nano crush.
Okay, some dye. Oh, still
More
macro.
diagonal need to
Still
go
a
in.
little diagonal needs.
Okay, now
Go.
that's good.
It's good now.
Yeah, that's good enough.
Okay.
Right? Okay, go up with the diag.
Ready? Okay, I'm going up now. This is 2.5.
Get us a new fielder. Yeah, 225.
It's a 22518. Okay.
Good.
12 atmosphere.
Okay, good.
14. We'll do one more. And then we pull back and try to open the ostium a little bit.
Okay, done.
Okay. Let's
We
pull
don't
this back.
say about that in.
Good.
We missed the ostium. Went in too much. Okay, done.
Okay. Now we are going to remove, as our bifurcate app, the balloon and the wire.
This step was not in the bifurcate app. Okay, some dye. You are good? We good? Some dye. Good. Okay, go up.
Going up on LED.
Mm-hmm.
So I know this has been a longer transmission and also a delay in starting, but I am sure
Down.
the viewers will appreciate a subtotal occlusion addressing
between
how
the
we
lines,
solved
not
the
every
issues
line.
about whether there was thrombus in the left
Look at
vein
the
as
pressure
well
now.
as
Show the hemodynamic one tracing. No.
Yeah,
They
better
let
now.
them show. Despite Impella, pressure has gone down to 80. See, this is the classical case. 70 blood pressure.
Okay, down.
While you are doing this simultaneous, look at that. This is the support with the balloon pump. Good. Okay. I mean, with the Impella, that's what the Impella support does. In these cases, although you can use balloon pump many times, but not give that extra support. Now, final step has to be the kissing balloon inflation.
We'll recross kiss it and we are good.
Recross and kiss. This wire is coming out. Good. Get a new wire. Okay. Let's show the picture. Because then kissing, if we can just do maybe off and we finish the case. Good. Pressure came up. LED wire still there.
Yeah.
Good. The guide is in.
Mm-hmm.
Good. Very good. Magnifying. I'm magnifying. Yeah. All right. Wow. Good. So just have to go through a strut and open it up. That's it. Very mini crush, right? Otherwise you see a lot of crushed material, which is not the case. Okay. So with that note, we can come back to our slide presentation, please. But show the fluoro continuously on the left side.
Show me get us a
Good.
2.5.
So now, just to take a message, that recent international trial from ESC
For the- no,
2019 and complete
For the
trial of
side
STEMI
branch.
strategy. Randomized clinical trial evaluating the
And then we
extended
can
role of
use-
ticagrelor in
No,
diabetic
202.
patients with a stable CAD failed to
And
show
then
any
what we do
benefit,
is we will-
largely
we have
due
a
to
2,
higher
right?
bleeding. So, however, prior PCI subgroups had net clinical benefit and no increase, the fatal bleeding. Also, elderly patients more than 70 years with ACS had better outcomes with clopidogrel versus more potent P2Y12 inhibitor and hence should be the first line therapy. Second, the strategy of complete revascularization done 1 day or 3 weeks later has shown to be superior to culprit vessel only PCI in STEMI patients with multivessel CAD as shown in the large randomized complete trial. I believe time has now come to change the STEMI guideline to make multivessel PCI as ACC class 1 indication in these patients. So 3 questions. Themis trial evaluated ticagrelor versus placebo in all following clinical scenario. Diabetes, prior PCI, stable CAD, prior MI within less than 1 year, or absence of stroke. Remember, the key was all except it was patients who did not have prior MI. Very important. So the D is the wrong answer. Then popular age trial compared the following scenario except patients with unstable angina, patients more than 70 years of age, patient with STEMI, clopidogrel versus ticagrelor or prasugrel, and patient with non-STEMI. Clearly, this was the trial of ACS and non-STEMI, not of the STEMI. So STEMI is the wrong answer. The last one, following are the results of complete trial of STEMI strategy except lower death and MI in complete revascularization group versus culprit, significantly lower death in complete revascularization group versus culprit only, lower ischemic revascularization in complete versus culprit only, similar bleeding rates between complete revascularization versus culprit, and similar stroke rates between complete revascularization versus culprit. Clearly, the answer is yes, but death rate was not significantly lower in the complete trial. So with that note, we complete our today's presentation, and we can just show the last.
Went in, so I'm now going to go with a 2.5 high pressure to the ostium with the kiss balloon. Okay, good. Down.
We can end it.
Yeah, would be very nice to see the final result.
Okay, give me the 2.5, and then what are we going to do to the LAD? 3.5 high pressure.
3.5 high pressure.
What length you have?
On the 15, 20, whichever you have.
20.
Okay.
Or even give me 12. I want to struggle.
The 2.5 side one is here.
And a 3.5 12. That's it. Here.
This is the case in our.
Uh-oh. Maybe a new one, right?
And that is you're advancing it into the diagonal, no?
Yeah, we did a 2.5. Okay,
Yeah,
good.
right. Here we go.
We did a 2.0 and then we needed
that
a
2.5
high
now?
yeah. Now 3.0 to the 3.5 to the LAD and the kissing, and we good. 3.5. We have 3.5. What is this? Yeah, 3.5. Yeah, that's enough. 3.5 to the LAD and the final kissing.
So, Samin, what is your plans for the upcoming TCT? Any presentations?
Yeah, we actually, you know what, because of I just came from the Sky meeting in India, Sky India, and so will be there only for 1 day on the 25th, that Thursday.
Good. Go, hi, 16.
And I can tell you that India, actually, our CCC live is very, very popular.
Down.
Right.
In the hall full of 900 candidates, there are like 80+% religiously watch, and that is why we know that between USA being 72% of our audience, and India is the second, which is about 17.8.
Let's do overlap.
Although we are just talking to our fellow here, Lorenzo.
Go up.
Italy is like 30th of the 130 countries. So maybe with him being here,
Lorenzo's, yes.
Down.
Lorenzo, maybe Lorenzo, you should talk to the Italian audience in Italian.
Yeah.
Tell them how important.
It.
Yes, well, hopefully some are watching and the message will grow. Lorenzo, what part of Italy?
Oh,
he's not mic'd up.
No, he's not mic'd up.
He's not mic'd
Milan.
up. Okay.
He's from Milan.
Milano. Okay.
Actually, we have the
neighborhood of Antonio Colombo.
Actually, Antonio is the one sent him here.
Perfect.
Yes.
Same hospital. It's a beautiful hospital. I have been there.
And Antonio was there in Delhi also in the Sky India meeting.
Right. So he went, I was chairing one of the sessions. He spoke at the ESC. So he went from there to India.
Yeah. All right.
Looks very
Wow.
good. Looks excellent.
Okay.
Samin, thank you. And Anu for a very interesting case. I believe this has been a very balanced transmission today, one which has balanced showing exceedingly complex case with multiple modalities, imaging, use of support catheter, as well as reviewing multiple trials presented at a very important meeting. With these words, we'll conclude today's case and see you on October 15 for our next session.
Thank